Good evening, everyone. Respected Dr. Patik Patel sir, esteemed member of IADP, and my dear doctors. A very warm welcome to all of you to yet another episode of Learn from our Master series organized by International Association for Dental Practice Excellence. Crossing 75 webinars has truly been an incredible journey, and we sincerely thank all the doctors who have been a part of our sessions. Your constant support and feedback motivates us to keep learning and growing together. For those joining us for the first time, we are International Association for Dental Practice Excellence, a platform built on the belief that quality education ensures predictable outcomes for dentists of every discipline and skill level. Dentistry is a continuously evolving science, and through our webinars and workshops, we aim to help dental professionals and enhance their clinical knowledge, refine their skills, and strengthen their practice. Now, without further delay, let's begin today's session of our Learn from our Master series, where the topic of discussion is Class 2 failures, hidden reasons nobody talks about, occlusal stress, C factor management, polymerization shrinkage hacks. Today's session will be led by none other than Dr. Patik Patel sir, a distinguished clinician, educator, and a speaker who has made exceptional contributions to the field of conservative dentistry, endodontics, and aesthetic dentistry. Dr. Patik Patel has completed his BDS from DDU Nadia and MDS from Karnavati Dental College. He has been practicing since 2015 at his private dental clinic, A to Z Dental Solutions, and also established his private dental academy in the same year, with a vision to provide comprehensive clinical training with modern skill enhancement and to uplift Indian dentistry standards. His professional journey includes several notable achievements. He has served as a national speaker for VOCO in 2019 and 2020 and as a national and international speaker for Mothers Dental in 2020. His excellence has been recognized with awards such as Junior Doctor of the Year by BMJ Awards in 2014, New Delhi, and Best Dental Academy of the Year by IHPA Awards in 2017, Pune, and also the Best Endodontic Case of the Year in 2019, Ahmedabad. And now, without further delay, I would like to warmly welcome Dr. Patik Patel sir to begin today's discussion.
Yes, good evening, everyone. So today we have about 1 hour to discuss about the class 2 failures. Basically, we'll try to make it as easy for everyone to understand. Am I audible? I hope I am audible. You can write in the chat box. Yes, ma'am.
Yeah.
I'm audible, right? Okay. So I'll share my slides. Okay. Is it full screen now?
No, doctor.
I have made my slide full screen.
Yeah. Yes.
It's full screen, right?
Yes, yes.
Okay. Okay. Just a minute. Yes. Okay, guys. So let's talk about something that nobody talks. Maybe few of the things that I'll talk is little bit different than what you might have heard or seen regarding the class twos. Yes. So myself, Dr. Pathik, MDS Cons and Endo, and I am a current fellow and mastership of GCOI implantology. So somebody has to talk, right? About nobody talks. Okay, I'll talk as I discussed. Some hidden, some half known, and some common things regarding class 2 composite restorations and how can they fail and what to do if they fail and how to manage them. And some common things that you might be seeing in the social media or you might have heard from other speakers. So, but many kinds of failure causes are there. Now, we'll start, of course, from the basics. Failure is not the opposite of success, it's part of success. So even if you fail in your class twos, make sure that you learn from your failure, that what was the reason. So today there is a learning session that we are going to do. So you learn from your failures, that this is the reason of my failure. This was the thing that I couldn't manage properly. Probable isolation, bonding, contact, caries removal, uh, so many different steps are there. One of the step or multiple steps may have gone wrong, but if you know, or you learn, you develop your skill, then those failures you can convert into success. So success is not final, failure is not fatal, it is the courage to continue that counts. So let's start. So in my practice, what I do is, for any class 2 DK, class 2 caries, or a failed class 2, or there is a fractured or a cracked tooth syndrome. Well, what I see is, why did this happen? Why the cavity happened at this place? Why the fracture line or crack line happened at this place? And why this class 2 composite or a GIC or whatever restoration it has been done, or a silver amalgam old, has failed. So what is the reason? What is the timeline? How long before, if the patient remembers, this has been done? And like 10-20% of my practice with failed class 2s or repeated attempts of class 2s come for dentists themselves. So they travel from local areas, or far areas from the city, or even outside state, for their class 2 restorations which are failing. Might have got it done locally, but they're not staying, maybe for a few months or 1 or 2 years, but they are not staying. Food is getting lodged, they are having some sensitivity, etc. So then I try to find the reason. What is the reason? Why? So is there any rotation of the tooth, or the adjacent two teeth are rotated? Is there any adjacent crown, because of which there can be sharp margins, or the crown margins is a very broad contact, a flattish contact? Overall, there is multiple decay in mouth. Are there any gum issues overall or localized to that particular area? If there are gum issues, there sometimes may be plunger cusp. So the bite of the patient again becomes very important. Bruxism, again, bite related, habit related. If the patient is under bruxism, the conventional techniques may fail, and you might have to also give night guards to your patients once you know he or she is having bruxism. Only then your restorations, your crowns, your prostheses, etc. would stay. And any other habit, of course, betel nut chewing or any other habits that the patient might have, uh, which they know but you may not know. So you need to know that first. So know the reason behind it. Plan your restorations, plan your contact areas, plan any built up that is required. Sometimes what happens is, when there is an occlusion, when there is a bite, and you see that the tooth is weared off, or there is a occlusal space 2 to 3 millimeters at the proximal area, you might sometimes need to little bit built up, rather than keeping it very shallow, because then in a big space there will be a lot of food lodgement. And sometimes when you cannot go with the direct, so you might have planned it wrong, that there is a big space, there is a cusp coverage required, uh, patient is a bruxer, and after knowing orbital nut chewer, and you know that here there has to be an indirect prosthesis, a bigger prosthesis covering the cusp, then do not plan the directs. So patient bite check. Plunger cusp, yes, this is a very less thing that people talk about, the speakers talk about. So I have made sure that one or two at least things that I can cover up. Plunger cusp, the sharp opposite cusp may be falling onto the margin of your restoration. Sometimes what we do is we create a margin of restoration and we fill our composite. But then if you see the bite, the upper opposing cusp would or might be falling exactly at the margin, and 100% that margin will break in future. So at that point, what to do? Ideally, any composite kind of material or even ceramics require 1.5 to 2 mm of thickness at the margins. As you can see here, there is a plunger cusp here, And because of that also there was a lot of food lodgement, and there is probability that the food lodgement would continue. So after the restoration, we'll show you this case. After the restoration, even the plunger cusp is rounded. Now your prep design, very important. So if you are working with a conventional box type prep, class 2 composite prep, just like you used to do for the amalgams, well, in composites, that things don't work because silver amalgam is different. It was mechanically retaining and it has different properties, physical, flexural modulus, etc. And composites have different properties. For composites, they bond and their bonding is best to the enamel. So if you prepare a box or a sharp cavity like this, see this case has failed. There is some composite as you can see here on the occlusal part, but the overall prep is such a way that there are sharp line angles. The contacts are not broken, not opened up, and you can also see that the crown here margins are also having issue. The crown might have been made earlier, and that time there would be a problem again because of food lodgement, because of cavity drilling by the previous dentist. There may be some dents on the ceramic, whatever, but you need to cover up, clear up everything before you proceed with the final restoration. So no traditional boxes, saucer shaped cavities, just like this. Have a look. You can click a picture of this before versus after. So in this cavity, as you can see, two things you can see. First is there won't be any line angles, any sharp line angles. It's more like a saucer shaped cavity, a spoon with a bevel kind of cavity, which is called a Calla Lily types prep. Next slide involves it. This is a modern class 2 Clark's cavity. What we say is the modern GVplex classification was in black and white era. Currently in the color era, we have the modern class 2 Clark's cavity designing. So as you can see, the complete bevels of all the margins here, I never involve the occlusal part in a class 2. Priorly, I also used to do all this kind of simple box type preparations, but since past 5 years, I have modified completely my entire designing. Once I came to know, learn about the Clark's cavity designs and the BioClears and the heated injection moldings and the different concepts. So old filling or there is a cavity extension. So as you can see, this is also one of the image that you can click, keep it with you so that you know that the entire cavity part has to be beveled. Uh, Grab as much enamel as you can. As you can see, this is my yesterday's case that I've done. Here, entire beveling. You cannot see any sharp margins. It's a total enamel bevel. So the entire area from here to here is a bevel. Of course, this 7 area is also entirely a bevel. And now you would place the matrix bands and wedge, and then eventually fill one of the class 2 when there are adjacent class 2s. First fill one of the class 2s, and then you can remove that band in that class 2, followed by now you place a ring on the remaining class 2 uh, restoration, and then restore. That is the protocol for two adjacent class 2s. Otherwise, again, you can fail if you place two bands, wedge, ring, and everything and fill them together. Again, there will be slight space. So you need to restore them one by one. Next point, managing adjacent teeth contours or cavities. So adjacent teeth has cavities. Of course, you need to restore them. Sometimes because of the cavities also, there are sharp, rough margins. You need to clear them off. Sometimes there is arrested decay. Again, for that also, you need to use discs, the coarse, medium, fine, super fine, and eventually give a slight curvature so that you don't want flat contacts. You always want curved contacts, and you want the contact point. You want the contact area and not a point. So area is at least 2 to 3 millimeters wide overall, vertically, horizontally, every way. So you want a contact area and not a point. To generate a contact area, you require some curve in the adjacent tooth also. So you need to modify the contours. Here, as you can see in the ceramic processes, There is a rough margin which I have, yes, smoothened with the discs and little bit polished as much as I could with a yellow banded burr. And finally, you can see the cavity prep and complete bevels. You won't most probably ever see any kind of margins, any kind of line angles that you can see. Even the gingival seat area enamel rim, 0.51 mm of enamel, if there is present or at the gingival seat, it is beautiful. It is the best thing you can have. So 360-degree enamel on the occlusal part, proximal part, and the gingival seat part. So there is minimum to zero chance of micro leakage in future, and the best bonding strategy, because enamel you can etch, dentin superficial you can etch, but middle third or the middle part of dentin or the deep dentin, do not ever etch. Now, next, getting the best out of your material. So if you are into the practice of uh, placing your regular syringes, make sure you are using high quality, good quality materials. Uh, Almost all good reputed companies have good quality materials. Make sure you use them. Try to use the same bonding agent and the same filling material. I try to use the same company bonding and the filling material, that is the flowable as well as the packable. Uh, that is easier. All have same chemistry, so helps eventually, or some way it would be helping, I guess. And now comes, if you know the technique, or if you learn it from someone, or if you've already learned, try to apply. Start using heated composites. This is an amazing revolution where the you don't need to heat the syringes. You can heat your flowable syringes, and then you can use compules, the packable composite compules that are available, and you can use in the dispensing gun. So you heat it. So in my practice, I use two kinds of materials. One is Dentsply Neospectra, second is 3M Filtech Bulk Fill, or the 3M 350Z Z350 XT. So for the Dentsply materials, I use 55 to 60 degree of temperature, and for the 3M 70 degree, which has been proven through years and years of research and articles. So by heating and minimum layering, eventually lot of layers. First layer small flowable, then a packable, then again a packable, etc. So multiple layers can also lead to micro leakage, small gaps or voids in between that are, or the flowables also may have entrapped bubbles. And eventually, because these are thick materials, they are cold when you use through the syringes, and also some air gets entrapped because you take from the syringe and with an instrument inside it into the cavity. Then you have to rely on your instrumentation part, the condensers and so many other stuff, and then you have to condense. Probably then you feel okay, now everything would have been flushed, but eventually it's proven everything is not that much flushed, and there are gaps, voids. So preheating composites improve the degree of conversion, stiffness, marginal adaptability, and micro hardness. Yes, the surface hardness of a heated composite when used is so good. You need to use it. My all the cases that I'm going to show today in the next few slides are with heating of composites. So now, if you can see this case, we can see a composite filling. So if this case has come to my clinic and patient has a problem that there is gap in between or there is underlying decay, I need to fill it up. So then there is big space. So I have to restore both the teeth. I have to take my cavity margins beyond the contact areas where there is no contact, of course, but I have to take it slightly beyond the proximal. So at the junction of the proximal and the buccal, or the proximal and the lingual surface, palatal and lingual surfaces, remove all the old restoration possible. And then, as you can see here, this is the heated composite. Well, here there is a contact is good, but the contact is above. It is not where I wanted. I want a embrasure area also. So this is a small mistake, probably at this area because of sharp and a higher contact. There can be black triangles below, and there can be some food lodgement from the sides. And because of the sharp and not rounded marginal ridge or the embrasure areas, there are chances, small chances that it may fracture in future, or because of horizontal food wedging from the sides, there can become slight increased space in future. So this is one of the error also that I did, and this case is about 6 months old. But eventually, I came to know, I took photographs, x-rays, everything, and came to know that what to do. This time, the matrices selection probably would have gone wrong. I wanted it a little bit below. So the next few slides have that thing. Now the matrizing and wedging. I won't go too much in detail about it, though this is a very important topic and depicts your class 2 success and failure. I would only say one thing, whatever matrices you're comfortable with, there are basically two types of matrices, metal and the transparent ones. Transparent are the BioClear ones. Metal matrices, one of the very good qualities are from Tor VM. They can be pre-contoured sectional matrices like this, or they can be the saddle matrix, as you all probably would be knowing. And along with that, there is a system. Then, so if you can use Garrison rings, you can use Palodent rings, and for the BioClear, you can use the BioClear rings. Personally, I use about 70-80% of the times the metal matrices, the pre-contoured sectional matrices. Now it depends if there is a little more space. More space means if the space is 0.5 to 0.75 millimeter in between two teeth, once your cavity prep is done, then I would be using the pre-contoured sectional matrices as they are shown in the figure with a ring, a Palodent or a Garrison ring. But if the space is 1 mm or plus, I would be ideally using a saddle matrices or a double curved pre-sectional, pre-contoured sectional matrices that are also again available from Tor VM, and they would suffice with the 1 to 1.5 mm up to the space that we need to close in between the teeth. But if it is beyond that, you ideally have to rely with the highly contoured, over contoured, double contoured BioClear or the transparent matrices, which will serve the purpose of your space that is little bit larger. And you can also use the spot weld technique with the BioClear matrices. That again is a different topic. So for the matrizing and wedging, select such kind of matrices depending upon the uh, cavity depth. So if your cavity depth, which you can measure with a Williams probe, a perio probe, if your cavity depth after preparing is from the occlusal surface is about 4.5 to 5 millimeters, you ideally have to use a matrix band which is 0.5 mm larger than your depth. So if it is a 5 mm depth, use a 5.5 millimeter matrices. Or in simple terms, the metal pre-contoured matrice, use a medium one. If your depth is around 4, 4.5, use a small one. If your depth is little bit around 6, 6.5, use a large one. If it is more deeper, then you go with the other kind of matrice or the BioClear matrice or the saddle matrices, which have a deep curve within. Wedges, again, selection of wedges is very important in my practice. These are the two wedges that I frequently use for almost all kind of cases. BioClear wedges, these are one of the favorite wedges. The yellow, blue, and the deep margin elevation wedge, which also is amazing. Sometimes to close out the space, the wedge may be, fitting little bit not that much tight. It would be going easily. So what you can do is you can even tie Teflon tape over your wedge, maybe 2 or 3 rounds, and then you can try. So that there are two advantages. One is it will be snugly fitting, more fitting that you than what it was, and secondly, there will be some kind of isolation, some kind of, because Teflon would lead to your blood and saliva and moisture, contamination away from your cavity. Same with the wooden wedge. As you all know, wooden absorbs moisture and leads to isolation, leads to a proper, minimum contamination area. But then it can also take up moisture within. And so wooden wedges, it's better to use the BioClear or the plastic wedges than the wooden wedges. But wooden wedges also can be modified sometimes and used more beautifully than any other wedge. there is one case we'll see. Bonding strategies according to the dentin depth. Just some knowledge that for superficial dentin, you can etch the dentin for 10 seconds for superficial dentin. Of course, enamel you need to always etch. Use such kind of gel-based etchants which do not flow inside your cavities. So you can etch the dentin for 10 seconds for the superficial dentin, where two of my most favorite bonding agents are universal bonding agent from 3M and from Dentsply. For moderately deep to deep dentin near pulp. Now, this is the area where your class 2s can fail. So when there is moderately deep or a deep dentin or a affected dentin or a sclerotic dentin where it's a black, dark brown color, but your spoon excavator or your round burrs or the cavity, uh, what do you say, the dies do not take up that area. And it is kind of just an affected dentin. In such areas, the dentin bonding strengths won't come much. It is a poor dentin area for bonding. But then there are techniques to make it little bit better, to hybridize that area. One of that bonding agent that is used is the Clearfill SE Bond 2 or the sixth generation bonding agents, which have a primer separate and a bonding bottle separate. So the primer would lead to a mild etching action or the conditioning or the priming action for the dentin. Uh, and the bonding agent is more of a plain bonding agent, so it will lead to a better bonding strengths, better penetration, and the dentin hypersensitivity chances are minimum. It will minimum open the dentinal tubules and create the osmotic pressure changes, and it will lead to a good hybridized layer. So best not to etch that dentin, which is moderately deep or very deep near pulp, and do not use universal bonding agents in those cases. Use sixth generation bonding system containing 10 MDP. So this is the area where 10 MDP is a monomer that would lead to uh, great bonding strengths, more penetration, and it will also leave the MMPs, the matrix metalloproteinase enzymes that are generated from the the collagen fibers when they get acid etched. So in this case, they are not going to trigger MMPs and eventually keep them at bay, which won't lead to eating of your bond eventually. So that's why 10 MDP is a very important monomer. This is a very important figure, as you can see. When your bonding strength is less than the polymerization stress. Now, when will the polymerization stress be higher? When there is a deep cavity and you fill up a flowable layer 1 to 2 mm, and above it you do a packable layering and everything one by one, step by step, quick, and 15, 20 seconds you give the light. Those are the areas where, because the dentin is poor, it's not very good in quality and it will break the bond there and then. So sometimes at the end of your restoration, you might even be seeing a black line. Half of the times it's the bond strength that is broken, half of the times there may be some decay that you have left out, or there can be some thickness of the bonding layer. It is very difficult to say. Eventually your patient will say that, okay, if he or she comes with sensitivity, if he or she comes with some pain, etc., that is the bonding failure. The thickness of bonding agent would not much hurt in the part of failure. But then when the bonding strength is better, then the polymerization stress, where of course the bond is going to stay for a long time. The light cure units, it's not like nobody talks about, but very few people talk about the light cure units. Very important. If you are using 5, 10, 15,000 light cure units, well, basically at the surface everything cures very nicely. The intensity is 1200, 1400, 1600, whatever the company tells you. But at the base, at 6 millimeters, the deepest layer of your bonding, the deepest first layer of your flowable, where it's going to be the best, and that layer has to be the most strongest because it's pure dentin. There is no enamel there. You require one of the best light that penetrates depth. So multiple companies do it. They have great lights, about 30, 40 plus thousand, like 50,000, 1 lakh, maybe more than that. So plan to invest in a very good high quality light that has an intensity of 1200 probably at the start, and that intensity does not drop to 800 or below at the 6 mm or 7 mm depth. You have to make sure of that. So in my practice, I'm using the 3M Deep Pure Aliper light. I have also used the Blue Phase light. Both are amazing lights. You can go for any one of them. Now, as I told you, there is the black line that you can see. So this is a fracture of the bond over there. Now, what is DWT protocol? So if you have a deep caries and you are going to do a routine class 2 restoration, though with the Kela Lily preps and though with the proper matrices, band, wedge, isolation, bonding, everything you are doing perfectly. But this step is extremely crucial. If not done, the bond can break because of less hybridized bond and shear soft. Now, what is DWT? So immediate dent in sealing, of course, but the idea is, so this is the idea. When immediate dentin sealing is carried out, immediate dentin sealing means whenever the dentin is exposed, you immediately seal it. First by the primer, as I've said, sixth generation, and followed by the dentin bonding agent that is along with the sixth generation. Many of the times, this technique also involves use of micro etchers so that the micro etcher particles, the air abrasive particles from aluminum oxide particles, they would lead to superficial etching of that part of that arrested dentin. Superficial, it's like very superficial, and it removes the smear layer, makes it more cleaner. Followed by, there is a CHX 2% disinfectant that you apply over that cavity with a micro brush. You leave it for 2 minutes and then you can wash it, dry it. Now you selective etch, then use the primer bonding of the sixth generation. Now, once the bond is cured, first layer of 0.5 millimeter good flexural modulus elasticity, which is near to dentin, like SDR plus from Dentsply. You can use Supreme Flowable from 3M. You can use GNL injectable from GNL. You can use Everex Flow, fiber reinforced, whatever. Just in 0.5 mm of thickness or thin layer, you apply it above that bond, the bond that you have already cured, and then you cure that bond, that flowable. Now you wait for at least 5 minutes because the dentin bond reaches 90% of its potential strength after 5 minutes. We are talking about the deep dentin, the one which we know that is not a good quality dentin. It needs more hybridization. It requires little more time for it to hybridize before you can place another layer, and then entire cavity gets blocked with your filling, and then everything gets cured together, and there is some amount of shrinkage and stress that comes on the cavity walls and at that dentin base. So by allowing the dentin bond to decouple with time, the bond is allowed to reach its full potential without being pulled towards the faster forming enamel or superficial dentin bond. So as you all know that the light curing happens, I mean the maximum curing happens, faster curing happens towards the light source. It's not that true. There are studies that it shows yes, but then they are old studies. The newer studies show that the faster bond strength or the faster curing happens where the bond is the strongest, which is at the enamel. Then what about dentin? So everything gets cured towards the enamel. So much stress comes on the dentin. And as a result, we want that to be really, really good, hybridized. And yes, before starting off your cavities, have you ever used a plaque disclosing agent on your teeth or the surrounding areas? Sometimes you may see some materia alba, some stains, some tartar. Always try to remove it with scalers, polish it with ester pastes. Still, they might be helpful to remove the biofilms by 50% If you want to remove them 100%, you might have to invest in a air blaster, the air abrasive units, which has again aluminum trihydroxide particles, powder particles, and then with the pressure, 30-50 microns of particle size, it removes the biofilms, and also some stains are also removed along that area. So you ideally have to use this once you prepare the cavity, and then you completely remove all the biofilms. Then you start with your isolation, followed by the matrizing, wedging, and the restoration. So finally, adjusting occlusions. In adjusting occlusion, very important. Sometimes what has happened that there is a cavity from little long time. The upper tooth might have slightly supra erupted, and the cusp might also be sharp, the opposing cusp. Well, after your restoration, sometimes what happens is you might feel that so much composite I have to remove. No doubt you might have given some good curves, some good anatomy also, but still you have to remove lots and lots. Then you have to make sure that some slight modification also has to be done to the opposing cusp, and not just to completely remove your restoration and make it either thin overall or at some point really, really deep, because at that point there is that high point. So adjusting occlusion. So what I do is in my practice, first I adjust the occlusions using the 100 microns paper, articulating paper, followed by the 40 micron at the last. So finally, once I use 400 microns, almost all contact points are okay. Now I use a 40 micron. And finally, with that, if there is one or two eye points, I try to remove it. And lastly, then I ask my patient, on the opposing side, are you feeling normal? All your teeth are touching, etc. Lateral excursion, very important. Please make sure you check high points on lateral excursion, because sometimes this is also the reason for your failure of class 2s once done. Because if there is high point, patient will have a periodontal ligament pain and eventually come to you with a TOP positive, or a sensitivity to the pulp, which then you remove and then you give medicines, etc., etc. And also that there can be, if not high point, in the lateral excursive movements, there can be interference that also you need to check. And the plunger cusp, as I already told, requires some rounding. So this is one of the case which you can see there is so much crack lines. Probably the patient would have a bruxism clenching habit because of so many craze lines on this particular tooth. But overall also I can see so many craze lines. One of the reason for also this crack food lodgement a little space was the improper contour of this 6 and 7. So if you can see, there is only the contact point here on the buccal aspect. Well, the contact point has to be probably more in the middle aspect, and there has to be little broader contact, not just on the buccal aspect. So I tried to manage as broad as the contact possible. Well, in this case, ideally also what I could have done was to involve the 7 and get a little less curve on the 6 distal. But anyways, what was allowed to me, I have done. The patient didn't allow me the second class 2. And as you can see, now this is all good, but there is a sharp marginal ridge. So after taking X-ray also, sometimes I modify, even that was sharp and little high, as you can see in the pre-op X-ray. But now it is almost at the level of 7. But yes, it was sharp. So then in the next visit, so this patient went away and then I observed it closely. So in the next visit, I tried to remove that sharp part with a disc, and then, coarse, medium, fine, superfine. And yeah, you can try to manage these things as much possible. Now, if you can see, the contact area is not totally at the height of the occlusion. It is at little bit below, which is around 1/3 the distance from the occlusal part to the, if you see from the vertical zone, 1/3 the occlusal part, and the middle third and the occlusal third junction. That is the point there where you need a contact area through proper selection of your matrices. Again, this case we have already seen. The challenge in this case was there was bigger space here. So if I used my saddle matrix, I used my Tor VM matrices, but eventually none of them helped me. Plus, another problem was the cavity depth was not that much, along with I couldn't manage the gingiva beautifully because the patient was under clopidogrel aspirin. So I didn't want to touch the gingiva. I had a recent stent surgery. So what I did then, I used the Palodent matrices. They are not super curved. They are slightly curved matrices, but the good thing is they are only of 30 microns, and so they can, they are pliable to instrumentation. So you can use your condensers, rounded condensers, and make them go as near to your contact of the molar as possible. Here I've used a modified wedge, as you can see in the above picture, because then what happened is when I was placing any other kind of wedge, there was a space coming in between these two teeth. When I used to observe the matrix bend, this tab, when I used to, just grab it and keep it below and used to check whether there is a space or not. So one of the very important key feature is please check after placing matrices, and when you place the wedge, physically check whether there is any space in between your adjacent teeth and your restoration teeth or not. If there is space at that point, or after placing the ring, if there is space at that point, there will be a space afterwards also, and it won't close by itself 100%. So at that point only, pick such kind of matrices and use such kind of wedge that does not give you a space in between two teeth, and there you can see a physical contact area developed. So as you can see, I could try and manage very nicely. Probably the contact area is minorly below the area which I want, but again, I'm satisfied with overall curve, overall contact, uh, everything. So thankfully, I could manage it. One another key factor in your class 2 failures would be uh, the proximal areas. You have to totally open it up, as I've already showed you, and it should be 100% beveled, and it should also be finished. You don't have to polish your overall bevels, but the bevels should be finished. You cannot keep your bevels rough, because again it can accumulate in future, because there may be biofilm surrounding, so it can accumulate again the micro leakage or the stresses. Now, this is a very ideal photograph. As you can see here, the band selection is such a way that, and the wedge selection is such a way that I have got a contact area over this part, and I am getting an embrasure over this part. So as you can see, I've got an embrasure, I've got good contact, and overall there is minimum to zero line of proximal area visible because of the heating of composites and the modern Clark's class 2 cavity prep designs. As you can see here, there is a very good finish polish. Nowadays, before I used to do a lot of groovings and lot of small stains. Nowadays, I don't do it often, especially in the cracked tooth syndromes, especially in patients where their bruxism do not create great anatomies, because then it can lead to stresses at that particular sharp points. Now, if you can see, yeah, so the patient needed to change. Okay, in this case, you need to inform your patient that, boss, the class 2 has happened. Again, comes to the first point, the cause of the class 2. The class 2 has happened because the prosthesis is having sharp, it's overhang of your ceramic processes. Because of that, there was food lodgement, and the teeth, there was decay. So now, after telling everything, the patient says no. Like in my case, the patient told, okay, let's see, in future we'll tell you, but at least I have informed. I know, so I have informed. And now comes the next part, that entire cavity is cleared up, uh, restoration done. And you also, as you can see in this part, if you can preserve a rim of enamel at the gingival seat area, that's the most beautiful thing you can do. But if there is no enamel, or if you have gone at the cementum area, well, if you know that cementum is little bit more mineralized than dentin, but it is quite less mineralized than enamel. So cementum requires a mild etchant, not our routine phosphoric acid. So for the cementum, you would require again the sixth generation bonding, where you can etch the cementum for 5 seconds, not more, because you don't want it too demineralized. And then after 5 seconds of etching, wash, use a primer. Then you use the sixth generation bond, You sometimes also can do dual cure bonding agent if the cavity depth is too great or towards the cementum. But then the protocols change, a little bit complexities come. So I'm telling you the simple phenomena. Just use 5 seconds of etching followed by priming, condition the using of sixth generation bond, prime bond, and followed by the first layer of flowable. Now, first layer of flowable at 1 to 2 millimeters, you can use it as just the flowable because then the cavity is quite deep, maybe around 8 millimeters. That deep, there is no bulk fill material that goes that deep, and you can cure it together. So 2 millimeters, you can use bulk fill flowable, 2 to 3 millimeters, and then the last 4 5 millimeters, you can use the packable bulk fills, or you can use in layers, 2 2 millimeters. Now, this case, very good case. See, one of the hidden reason of a class 2 failure, which nobody talks. This is one thing that nobody talks. So after your cavity prep, if you are doing in the rubber dam, the cavity prep also, you probably might not be able to check, then pre-check it, pre-check your occlusion before starting the cavity prep under rubber dam. Half of the times I prepare the cavity and then apply the rubber dam and then restore it. Half of the times I use rubber dam from start, and few of the times I do not use rubber dam. That depends on patient to patient, depends on my comfort and patient's comfort, my time that I have. Uh, am I fully under energy, and so many things are there. But 80 90% of the times for any kind of restoration or endo, we use rubber dam in our practice, and you should too. Bonding isolation best under rubber dam. So as you can see here, here there is enough space I mean the proximal area. But if you see at the bevel area, there is only about less than 0.5 millimeter, and the lower teeth entire buccal cusp is coming at that area. So what if my restoration is only this much thin at this portion? It will surely break or grind itself, and there will be eventually maybe the cusp fracture that happens of the treated tooth. So then what I did was I increased that cavity thickness and increased. Uh, I hope I have a picture. Yes, I have a picture. So as you can see here, then there is a space that I created a little bit more, and then I filled it up, bulked up the material. And as you can see, the bulked up material now also touches the opposing teeth, but lateral excursions are also checked. Now, this is what I was talking about. After placing, this is a double curved matrice band. As you can see, it's very nicely curved. And I have used a wooden wedge. But then after placing the wedge, sometimes there happens a space. Then contact is still open, then wrong. I either you change the wedge or you change the band. So in here, then I used a Palodent matrix band and then applied the wedge, modified it slightly. Now it's correct, followed by ring placement and everything. And as you can see, yes, here I got a very good contact. See here, the patient had food lodgement issues and a mild decay in between two teeth because the contact was little bit open and there was only buccal contact. Now I brought the contact in the middle area, as you can see, and both sides. Palatally is a larger embrasure, buccally is little bit smaller. It's always like this, as you can even see in the natural dentition. And now everything works. As you can see the radiographs, I have got a good bulk and overall good hermetic seal. I have enamel at the base also, so I've grabbed everything as much best as I can. As you can see, the teeth are hypoplastic, so I have etched the premolar little bit more, not 20 seconds. I etched it for 35 to 40 seconds, 15 seconds more, followed by, yes. So this case, old class 2 GIC, everything removed. And as you can see, the preps are done, Kela Lily preps, and both bands placed. So one more error, both the bands placed and ring placed. Nowadays, I don't do this. I placed both the bands, restore one of the tooth without ring, followed by then I remove that band and then the other tooth with ring, as you can see here, and finally get contacts. But this was a little more occlusal contact, which I didn't want. Now, what was the reason for this failure of this class 2 composite and food lodgement? Because of proper, the improper old contact of restoration. And So in our case now, at least we have made sure that we have bulked up the 7 because it is slightly mesially tilted, as you can see in the pre-operative X-ray. And because of that, there was a ditch that was forming. So I have to correct it, because then again, if I have a same kind of restoration, again the food will get lodged. So these are not just simple class 2 composites. These are complex restorations where you need to see so many things. You need to see the tooth rotations are there or not. You need to see the marginal ridge mismatches if present. You need to see the plunger cusp. You need to see the bite of the patient, lateral chewing, bruxism is there or not, you know, multiple things, adjacent tooth contacts, you need to contour them, so many things. So one such case, another case, yes, this is a yellow bioclear wedge, a very beautiful wedge. Since the patient was an ortho patient and ongoing aligner patient, which we did this fillings. And as you can see, everything is beautiful. There is no overhang. One more reason for failure of your class 2 is if you have overhang or if you have underfilling, both can lead to a failure, sure shot. Now, if you have such kind of restoration, I mean, if you do it and then take an X-ray and if you find, oh boss, there is some underfilling, please try to remove it there and then, or call the patient next time and remove that and redo it. Do not feel that if it fails or if the patient complains, I will do it later. Well, he or she may not complain immediately, but there will be a complaint after some time. We don't know, after a few months, year, 2 years, maybe few more years. So this is the BioClear matrices and the BioClear ring as has been placed here. Now, if you can see in this case, why have I kept this? Because there is a issue with the contact area. See, the tooth are rotated. Now, I have tried to manage this as best as I can. The premolar has a cavity, the molar, the 6 has a MO cavity, a 7 also had a cavity. Now, what to do? So I tried to restore them one by one. And now, if you can see, you feel as if the tooth are not rotated much anymore. So this is the beauty. These are complex class 2 restorations where you need to sometimes make sure that the contacts areas are beautiful. They are broader, they are a little bit wider depending on case to case, and they come more of in the center of the two teeth rather than they are more palatally or more buccally. As you can see here in the molar also, that this is also beautiful contact. Now this case, again, modification of the ceramics, as we have already discussed this case. Here I had used this MyClip 2.0 case. Unfortunately, couldn't use rubber dam, but as you can see, there is a contact, but this system leads to a flattish contact. So usually this kind of system I use when there are crowns, adjacent crowns. So this is one yesterday's case. We are like last 3 cases of the presentation. Yesterday's case, malaligned posterior teeth. As you can see, there is huge class 3 occlusion, a complete crossbite that you can see here, which 100% would have led to the cavity and food lodgement in between two teeth. Plus, there is some rotation in between these two teeth also. And as you can see, the cavities are so deep initial, but extremely difficult for us to manage as dentists. Now, sometimes there can also be errors in rubber dam. So improper placement of rubber dam can also lead to failure. Like for in this case, or in deep class 2 cavity cases, if sometimes you have not managed your gingiva properly, like with a burr, with laser, with cautery, you need to slice down your gingiva, especially if it's inflamed or coming above your gingival seat area. You need to slice it down, and then you need to use an hemostatic agent to stop the bleeding, then followed by you place band wedge restore or place the rubber dam and restore. So in this case, there was some issue. There is a space, as you can see, the rubber dam sheet is slightly above. This was solved. Teflon was used inside in this layer, and this was tried. I mean, I tried to solve it with even a floss tie surrounding the area, followed by a one restoration after another. And yes, if you can see here, the contact area was somewhere here because this tooth was more buccally. Now, I have tried to keep it as centric in between two teeth as possible, as you can see here. So from slight change from this contact here to this contact in between probably might lead to solution of my patient's problem. And as you can see, I could do a very conservative, good, deep class twos. And again, the bite. God help this guy. Proper sealing of enamel 360-degree is extremely important. As you can see, here there are no margins visible on my composite. Can you see any margin on this class 2 that you can tell, yes, doctor, I can see one margin here, one margin here, and it is, exactly. So when you prepare a box type cavity or when you use routine syringe flowables and layering techniques, such kind of beautiful flow and invisible margin kind of restorations may not be possible. Now, today morning, I did this case of a dentist herself who came about 25 kilometers away to my practice. And she had this deep class 2 where she had sometimes some sensitivity, not too much. And then, as you can see, there is a deep class 2, but the reason for this class 2 is the supra erupted upper 8. So obviously, today to use this 8 for my bend and wedge, I did not remove it. I have told her to get it removed, that she'll come after a month because of the festive season. But then, so what we did was first we removed all the decay. This is that sclerotic, blackish, dark brown dentine I was talking about. That is not good for your bonding. And then this is the hidden reason for your bond failures also. Now, how to manage this, we'll tell you. Now, what has been done? Can you see this hypoplastic cusp and the thinning cusp? One more reason of your class 2 failures, if you have kept very thin cusp after your cavity prep because of the decay or because of your beveling or whatever, you sometimes have to check if there is less than 2.5 millimeters of dentine thickness under your cusp. You need to cap your cusp. Take the cusp down by 1.5 to 2 millimeters and then add that much composite bulk. You can manage this with a direct restoration. So in this case, as you can see, I have managed it with a direct restoration. The cusp is down now. Overall, the cavity is as de-sharpened as possible. Overall, as much bevels given as possible, and followed by a deep, nice restoration that was done following all the concepts. The concept of, the isolation, bonding, the bonding strategies, which includes the CHX cavity disinfectant, sixth generation bonding system, selective etching, sixth generation bonding system, decoupling with time, followed by the restoration in layers, 0.5 mm above that first layer, first flowable 0.5 mm decoupling with time. You wait for 5 minutes, then you lead to so here even Everex flow was used as the internal base because the cavity was quite wide. Patient's occlusion was also quite uh, deep and odd. So to counteract the stresses. And finally, a case where there was some crack, the overall crack and the caries, it was more of caries opened up. Now here what I would have probably done is I could have done a crack dam procedure. That is also a very vast subject. And you can see here sharp enamel. It's a very good enamel at the base, but you don't want this sharp enamel. So after the clicking this photograph and before starting with the etching and bonding, I did remove or de-sharpen this sharp enamel with my instrument, and then followed by, as you can see, hermetic. There is minor overhang, slight, won't affect, but anyways, but here you can see a complete good broad contact, but not over broad, just like it was priorly. And the patient had a cracked tooth syndrome. Now the patient had angry nature, so she told me, yes, I would do jaws, muscles tightening and everything. So I told her not to do that, and she might be doing some bruxism. So I have advised also the night guard for the safety of your restoration and for the safety of her teeth also. So this was all about class 2 failures that I could manage to cover up in 1 hour. So as I run the academy also, we have our upcoming programs. If anyone is interested, please DM me or share me your details or the interest on my Instagram or on my WhatsApp number. Next is my number. So as you can see here, there is a Prostho Crown and Bridge Dentistry course. This is the 51st batch of Endo workshop. This is a flagship course of my academy. 3 days of Endo with so much learning, fully hands-on course. And so this is me, Dr. Pathik Patel. This is my phone number, mail ID. Values aren't taught by what we say, they are taught by our example. I hope I could give you some insight into this topic, as much details I could give in an hour. So many things are surely not covered, but hope to see you all soon. And thank you, thanks a lot.
Thank you so much, Dr. Pradeep Patel, sir,
Yep,
uh, uh, for sharing your valuable knowledge and expertise on class 2 failures, hidden reasons nobody talks about. I'm sure all of us are leaving this session with practical insights and techniques that we can apply in our daily clinical practice. A heartfelt thanks to all the doctors for your attentive listening and enthusiastic participation. I hope everyone departs this session with renewed confidence and inspiration. Once again, thank you, Doctor. It was truly a wonderful and informative session, and we deeply appreciate the time and effort you dedicated to being a part of this series. Please do
thank
check
you.
and follow Dr. Pradeep Patel's Instagram page to explore and appreciate his excellent clinical work. To stay updated on our upcoming webinars and workshops, please visit www.iadp.org and don't forget to follow our Instagram and Facebook pages. If you missed any of our previous sessions, you can find them on our YouTube channel. And we would greatly appreciate your support by subscribing. Thank you all once again and have a wonderful night ahead.
Thank you, everyone.
Bye, Doctor.
Bye.
Bye bye.